Okay, and broadcasting start. Hello, everybody. Good afternoon, good evening, and good morning to everyone and all in whichever part of the world you are sitting. Today's agenda of meeting here is learning about interdisciplinary orthodontics. And that is about adhesive dentistry, cosmetic dentistry, and orthodontics. How we can combine the knowledge of orthodontics along with the adhesive dentistry and restorative dentistry for the benefit of the patient so that the treatment time can be reduced, so that the cost can be reduced, and we can give the amazing results. And to deliver the talk, we have none other than a very good speaker for the topic, Dr. Elio Boschetti. He is a DSD certified digital smile design doctor. He is a certified member of European Society of Cosmetic Dentistry. He's a supervisor of dental aesthetics, Department of Orthodontics, University of Cagliari, Italy. He's an assistant professor, dental aesthetics, United Campus of Malta, in Malta. 2018 to 20, he's a visiting professor at postgraduate course of restorative dentistry at University of Foggia, Italy. Without wasting much of a time, I would tell Dr. Elio to take over. And before he takes over, let me just introduce to some of the panelists who have joined today. We have with us Dr. Mandava Prasad. He's a professor and head in Narayan Dental College in Orthodontics. Hello, Dr. Mandava. Welcome. We have Dr. Kamal Bagda. He's a professor and head, Department of Restorative Dentistry and Endodontics at Narsibai Patel Dental College in my own university, Sakarjal Patel University. Then we have Dr. Sonali Kapoor.
Hello.
She is a professor as well as a dean of Manubhai Patel Dental College. Welcome you all, Dr. Kamal, Dr. Sonali, Dr. Mandava. Thank you for joining. Dr. Elio, all good to go. Thank you.
Thank you, Dr. Ajay, for your kind introduction. And I want to really say hello to everyone. I'm very honored to be connected with you to share my experience about orthodontics and adhesive dentistry. My presentation today, it's going to be maybe a little bit more about restorative, but what I really want to share with you, it's the point that when we work in team, or even if we work alone and we do both ortho and restorative, we really need to share and have the same vision with our team, and it is really crucial, essential to achieve the excellence. So as Dr. Ajay said, I come from Italy, actually from the north east of Italy. It's a small city named Vicenza next to Venice. And as already said, I'm an active member of the European Society of Cosmetic Dentistry and an active member of Amici di Brugge, that it's a pretty an historical association of dentists in Italy. And that's the university where I come from, and actually where I'm working, and as well the University of Cagliari in Sardinian Island in south of Italy. And as well I'm working at the UCM, United Campus of Malta. I think that is a pretty nice and cool institution, because the people that are graduated in this institution, they have recognized their title in the all Europe, and as well the postgraduate program are pretty nice. So I'm pretty honored to be a member of this university. And this is my city where I come from. This is the main square. It is Vicenza. And we can see here during the Christmas time, we in Italy like a lot lights. I know that you like as well lights, because I've been in India during the Diwali, and it was really amazing. And you can see here some picture of my hometown. There is a pretty historical theater, the most famous house in our city. And this is, of course, Agrafort, because I told you a couple of years ago I've been in India and I traveled around and I had such amazing time. So I want to share with you some little picture that I personally taken. But today we are talking about aesthetic dentistry, so smile aesthetics. Why smile aesthetics is so important? Basically, because eyes and smile are the parts of our face that most transmit emotion. And so they have a really huge impact in social life and relationship. In fact, we have to think that we actually show our teeth pretty often. So while we are smiling, laughing, speaking, and even when we are complaining or where we are angry, we actually show our teeth. And it's really well shown in literature that the part that are most watched from everyone, not only from dentists, in our face are eyes and smile and teeth, mouth, basically for the reasons that we just mentioned. And before to start, we really have to underline that we could have a good oral hygiene, like in those cases, without having such a nice dental aesthetics, smile aesthetics, but is never ever true the opposite. So we will never have a good smile aesthetics without a good oral health. So before to start every kind of treatment, no matter if it is ortho, surgery, or even restorative, we always have to check, first of all, the oral health and, of course, the periodontal health. So in our starting kit, of course, we have the Explorer, the mirror, but of course, we cannot miss the perioprobe. And so going back to aesthetics, we know that 97% of adult patients that undergo ortho treatment, they wish to correct their malocclusion for aesthetic reason. And only 50% of adult patients are fully satisfied with their smile. So we actually have a lot of work to do. And this is another picture from India. I really felt in love with your culture and your amazing tissue. It really was great. And this is me wearing one of your wonderful dress. So as I told you, I really had a great time in India. So going back to presentation, can we say that it's a good results? Those are some direct composite that we're gonna see later. The truth is that we cannot really say that it's a good result or not. Apparently, yes, but we cannot really be sure that it's a good result because we are missing the smile and we're missing the face. And so when we do an aesthetic evaluation, one more time, no matter if we will do ortho, restorative, or prosto, but the aesthetic evaluation needs to be always the same. So we have to start with a global approach, and we start from outside and we move in. So, and we actually can make a kind of a checklist. And I'm sorry, I'm going to be very fast because usually in my courses, this part takes almost one day, but we are gonna see that very briefly, and then we're going to see some clinical cases, of course. So, of course, we start with the macro aesthetics that we can capture with some pictures, or I would suggest you as well with some video. And so we're going to check the face symmetry, the lower facial height, the profile analysis. So we're going to check the face protrusion, and as well we are gonna check the lip thickness, the labial competence, and as well the facial midline and the interincisal line, and we are gonna see that they coincide or not, if they are the same or not. Then we are gonna move to the smile, so we are gonna check the mini aesthetic, and so we will check the smile curtain, the philtrum hay, the commissure hay, the maxillary incisor exposure, and we're gonna check this exposure at rest, during at smile, and as well during the laughing and during the speaking, so during the function. And of course, we are going to check the gingival zenith, so the gingival display, and the labial corridors. And I really recommend you, as I just said, that we cannot only ask to the patient, smile and take the picture, because the patient is gonna show us just a posed smile, not a really natural smile. So we have to be able to capture, as I'm showing you with the arrow, the posed smile, but as well we need to find and capture the widest smile exposure as possible, because it really can change our treatment plan. Because are we gonna need a perio-surgery or not, and how are we gonna fix those zenith? Do we need to do that or not? So we really need to try to capture the widest smile as possible. And only at the end, we are gonna focus on micro aesthetics. And so we are gonna check the teeth proportion, the teeth shape, the crown height, the incisal edge, and of course the periodontium and the teeth shade. And as well the texture of the teeth surface. Why is that so important? Basically, I want to share with you this very easy and simple drawing that I did. As you can see, we can see here two identical center incisor, and we can see here the shape. And if we play with the transitional lane angle, the vertical grooves, and the perichymata, even we are having exactly the same shape, we can change how they look like. And it is very important because we can really play a lot. And when we are playing with those line and grooves, basically we are changing the way the light interacts with the teeth surface. And if we change how the light interact, basically we are changing their shape. And so we really need to put our attention even in those little characteristics. And I wanted to put this slide because I really want you to think about how is important the arch form. And because looking at the arch form, we can really understand that it has a key role on the frontal teeth display and how they look aligned or not. And we can immediately, looking a picture, an occlusal picture, we can immediately figure out how we can improve the frontal teeth display. And we can already figure out if we're gonna do that with ortho or with restorative, or both of them, of course. And those pictures are taken from a US book of orthodontics and aesthetics. And in those pictures, there is a chapter about the finishing, and those pictures want to show to the readers how we can improve the smile aesthetics with the direct composite. But when I saw those pictures, I wasn't so comfortable because, okay, it's not a bad result, but actually we can achieve way much better result. And we have to be careful to avoid some mistakes that are very easy to avoid. For instance, here they wanted to close the black triangle, but actually they produced a canted midline. And as well here, those look that they were aligned after ortho, now they look the kind of rotated. And so what I want to share with you is how we can avoid this little mistake and how we can improve the finishing phase after ortho, and how we can combine ortho and restorative as well, direct and indirect restorative. And another picture that I made when I was in India, and, an amazing trip, and it is the amazing Taj Mahal. And I had as well a great time in Khajuraho. I love that place, very peaceful. I enjoyed so much India, as I told you. So I don't want to bother you with adhesion. We don't have the time, but we know that if we work on enamel, we are going to have an amazing adhesion. A little bit less if we work on dentin, but the key point is that we really need to work on a clean and dry surface. Adhesion, I think that is amazing because it permits us to be really minimal invasive, achieving great results in both functional and aesthetics as well. So, and of course, rubber dam, it plays a key role. And I have no doubt that every one of you can make a nice restoration without rubber dam, but probably only one tooth at the time. So one of the major advantages of using rubber dam is that we can restore several teeth in just one time. And actually it's a pretty big advantage because so the patient can come to our office just a couple of times and not hundreds. And as well, it's going to be more profitable for us that we are going to restore several teeth in one time. And as well, we are going to work in a very clean and more precise way. So, and for instance, 5 years ago, I went to Nepal for a voluntary program. And here as well, I was using rubber dam. Of course, I wasn't doing any kind of fancy dentistry or aesthetic dentistry, but our goal are always the same. So to restore as many teeth as possible in the best way we can to provide to our patient long-last restoration. And so we always have to check the face proportion and as well the face symmetry. And after that, what we want to recreate, it's a nice smile that is perfectly balanced with the face of the patient. I already saw that you had a digital smile design lecture, so it's something that I'm going to be super fast. And if we look at that smile, we can immediately see what we would like to change and how we could improve a smile like that. So please don't misunderstand me. Of course, we, as I just told you, we are gonna have our diagnosis, our diagnosis on pictures analysis, X-rays analysis, and stone model, or today more likely digital model. And as well, we're gonna check the cephalometric analysis and so on. But we have as well to analyze the smile, because as we said at the beginning, a lot of the patients, they want to undergo the treatment for aesthetic reason, and the aesthetic and what they can really see and appreciate is the smile. So if we check that smile, I'm pretty sure that almost all of you, the first thing that you noticed is that this canting on the occlusal plane. And a lot of you for sure had saw the midline canted, and maybe not 100% of you saw that this lateral incisor is not as wide as the contralateral, so it's a narrower lateral incisor, and that this canine is rotated. And so only looking at that picture, we can immediately see how we would like to improve a smile like that. And looking at that, so we can immediately understand where and how we are going to put our braces, and we already know that we need to open up a little bit this space to allow to the restorative dentist or to ourselves, if we do ortho and restorative, to restore the lateral incisor at the end of the treatment. And if we like to do that with the direct composite or with ceramics, it's another, we can decide, but we cannot miss, of course, the right treatment plan and the right diagnosis. And as well, if we look a smile like this one, as I told you in advance, we really need to try to catch the widest smile exposure as possible. One more time, I'm inviting you to check what would you like to change looking at that smile. And for sure, I'm pretty sure that all of you can immediately see how narrow looks this arch. And there is something as well about the teeth shape that doesn't strike us. And of course, the crowding on the lower arch. So one more time, we have to make, of course, I would like to say in the old way diagnosis, so looking at the chef, at the picture and the stone model, but we have to look as well at the face and at the smile. And one more time, now it's very easy because we already know what we would like to change to improve a lot the aesthetics of the smile of that patient. So that's what is going to be our treatment plan. And so doing that, we can immediately see that for sure we are going to do ortho, but as well we will need to change the shape of those teeth, and maybe we will need as well a little perio surgery. And sometimes the treatment plan, it's a little bit more complicated, like this one, and other time it's pretty easy, like in that case, just finished ortho, but there is something that is affecting the smile arc. Very easy to understand and very easy to fix. Just in, I'm not joking, 15 minutes of a restorative dentist, just with one shade, one layer of composite, we can completely change the smile exposure and as well the patient satisfaction. And here some picture of Agra when I came in India, and as well I enjoyed the Ganga River. I made a little trip on Ganga River. So we just saw how we can play a little bit with the smile picture. We can draw the new smile shape and we can move those teeth. But actually we can do it directly on the mouth of the patients. And it's pretty nice to make it, to understand if our thoughts are right, and as well to show that to the patient. So how we can pre-visualize our treatment plan. So we can do it with the mock-up, and of course we have several mock-up. The first one is the digital mock-up. We have a direct, semi-direct, and indirect. So talking about digital, I don't love actually digital mock-up because, okay, it's nice to show to the patients, but with the digital mock-up, it's kind of a video game. We can put the teeth everywhere, and so it's kind of easy to make a mistake if we don't pay attention. But I don't love digital mock-up because we cannot make any kind of functional try-in, and as well speaking analysis. Of course, we cannot do that with digital mockup. So what I really like to do is the direct mockup. So we can use a little bit of composite, so just a regular composite or flowable composite, and we can layer the composite directly on the teeth of the patient. Of course, we are not etching the enamel, and we're not having any kind of adhesion. We are just adding some composite to figure out if our treatment plan is it's correct, and if we like it or not. With this kind of mock-up, we can make for sure some aesthetics analysis, but as well functional analysis, phonetic analysis, and chewing analysis as well. And it is pretty useful not only for restorative but for ortho as well, because in a case like that one with this abrasion and maybe erosion as well, where are we gonna put our braces? Of course, we have to consider the right dimension of the tooth. And the indirect mock-up, and the indirect mock-up, it is 100% made by the technician. I use that hardly ever. What I really prefer to use is the semi-direct mock-up. So those holes are going to be filled with the resin, but we're going to see that later on, and it's going to be directly printed on the mouth of the patient. But let's check that smile. So this lady, she was complaining for the color of the upper right central incisor, and I was pretty surprised when I saw that tooth, it was and it is vital. So, and I thought immediately we can make some veneers, and everything is going to be so amazing. So I'm gonna prep a little bit more that tooth to mask the dark color, but actually she couldn't afford veneers. So we really have to think in a non-invasive way, and as well in an adhesive, non-invasive way, and on the other hand in an adhesive way. So what I did basically, it was just an external bleaching, and that's what we achieved. Still, it is slightly darker. And then after we achieved that, I just played a little bit with the true direct composite restoration, and that's what we achieved after only 1 hour. 1.5 hours of working. So I reshape. I liked the level of the incisal margin of that tooth, so I just copy that, and I improve as well the surface of that tooth. And that's what we achieved in a very easy and very economical way. For us and for the patient, just a couple of appointments. And so speaking about direct composite, is something that is pretty useful as well for orthodontists. It is the same case. So here it's during the layering, and here it's during the finishing phase. And that we usually, that's what we do usually. So at first we layer the palatal envelope, the palatal surface, then we layer the dentin anatomy, choosing the right shade, and at the end we cover everything with the last layer of enamel. And it is so important the finishing phase, because as I told you before, playing with the surface, we can really change how they look like. You can see here the teeth, how they look squared and flat, and here how they look natural and even slightly longer. Actually, the teeth are the same, and those they are kind of short for occlusal reasons that is not the topic of today, actually. But playing with the transitional line angle, with the embrasure, and as well checking the right proportion, we can achieve a pretty nice result, even if the length and the width, they are not 100% perfect. And looking at that case that I want to share with you, this is a very young patient, only 18 years old, and she saw something about the veneers, some advertisement. So she came in my office to have a veneers treatment. And we can see that they are not perfectly aligned. So what I took an impression, and I asked to my technician to make a wax up to check how they could be doing veneers. And that's the silicone guide. And you can see how invasive we would be if I do veneers in a case like that. Here, I would need to open a pretty big space to improve the midline and to allow to make space for ceramics. And here as well, I would drill away the whole enamel, and I would go in on dentin. So, but I really thought about that, and I immediately decided that first of all, I needed to make those teeth aligned, and then I could restore them, because I'm 100%. I 100% agree with this article that really would push us to be more conservative as possible, especially in young patients, but I would say with everyone. So I told her that we're gonna do an ortho phase, sorry, and she said, "No way, I'm gonna wear braces, because I don't wanna wear braces." And actually, we could do it with aligners, but we know that unless we make in our dental office directly aligners, and actually I'm not prepared to do that. Aligners are expensive, maybe too expensive for an easy case like that one. So what I decided to do, it was to bond directly on the labial surface this night eye arch wire, and let it align my teeth. And we can see immediately after 1 month and a half, they look already way better aligned, except for this lateral incisor that it is a little bit backward. So what I did, exactly like in every straight wire technique, where the information of the information are in the braces, I added a little bit of composite here in order to make the arch wire to push a little bit forward the lateral incisor. And that's what we achieved in actually 3 months of treatment, and it was a very easy treatment. It is a good alignment, not perfect, but more than enough to make our restoration. So that's what we achieved after we aligned the teeth. And so one more time, we can draw our final project. And I think that is pretty nice, because we switched from a 6 veneers treatment plan to just 2 direct restoration. And that's what I did. And you can see here the rubber dam is not perfectly placed. I don't remember that day for sure. I was pretty in rush, and maybe I was fighting a little bit with rubber dam. So a little tips that I want to give you. Look, those are just ortho elastics that I use that just to fix the rubber dam in order to be super fast, super quick. And what I did is the same procedure that we just saw 30 seconds ago. So the palatal surface, then the dentin, a little bit of some effects, and at the end, last layer of enamel. And that's what I achieved. And the result actually doesn't strike me. I'm not so satisfied. Why I would like to share with you that this is my mistake, because maybe I got the shade, but actually not really the shape. We can see that is it looks a little bit wider, and as well a little bit too longer. And so and we can check the smile picture. We can see that we cannot notice that much that is longer. Maybe we can notice that is a little bit wider. And as well, actually, I missed a bit as well the lateral incisor, that it looks a little bit too long. So how we can make up for this little mistake? And as well, I took those pictures. Actually, they looks okay, but not such amazing. And as well, we talked about the texture, and we can see here, I tried to copy the texture, but I didn't get it 100%. So very easy. One more time, we know that aesthetics is in the details. So I call back the patient, and I'm not joking, in 15 minutes, we can fix this little mistake. Just with a diamond disc, we can one more time play with the shape, and as well those angles. And after 15 minutes of finishing, that's what I got. Still, it looks a little bit longer, but as we saw in the previous smile picture, I'm meaning that one, we have a little bit of a lower lip asymmetry. So looking at the picture, we already know how to fix our teeth. And that's what I got. And now I can say that I'm 100% satisfied with my work, because we cannot recognize any difference between the tooth that we restore and the natural tooth. So I fixed the lateral incisor and the upper right central incisor. What I like about that case, it's okay, yeah, for sure, the final result, but the actually non-invasive way we can do these kind of things. So from veneers to just to direct composite. And if we look at that smile, this is a case that I took from a colleague that share on Facebook. It is an Italian colleague, and he fixed this missing two lateral incisor in that way. One more time, we really have to be critical with ourselves, first of all, but as well with all of kind of work that we see around. And but not because we have to be mean, but because we have to learn from our mistake, and as well from the others' colleague mistake. I think that we can really learn a lot from our and others' mistakes. So what we don't like about the final results. Of course, the central incisor, they look too long, but maybe they aren't too long. They are just too narrow. And the lateral incisor, of course, those are canine that they were moved a little bit majorly, and then they made a reshape. But still, they are maybe too big to be lateral incisor, or in other words, they are too big respect those central incisor. And it permits me to introduce the last topic of today that I want to share with you. What about central incisors in case of agenesis or microdontia of lateral incisor? And it is a really crucial topic for everyone, for restorative dentistry, dentists, sorry, and as well for orthodontists. So we know from the literature, just to make a very long story short, I made a pretty long literature review about this topic, and what we can say at the end, you can see on that slide. We know from the literature that when we have a microdontia of lateral incisor, like this one or both lateral incisor, we are gonna have a mean reduction on the measured distal width of 0.3 millimeters. And when we have one or both lateral incisor, missing lateral incisor, we are gonna have a reduction of the measured distal width of the central incisor of 0.45 millimeters. Of course, they are the mean of the values. Sometimes it's gonna be more, other times it's going to be less, but we know that those are extremely often reduced. And as well, we know that when we have an agenesis, the central incisor, they tend to have, sorry, a little bit more rectangular shape instead of round shape. And when we have one missing lateral incisor, we have almost a 50% probability that the contralateral, it's a narrower, so peg shape or narrower. And it changed completely our diagnosis and our treatment plan, because we really have to be 100% agree with this article of Marco Rosa and Zachrison. Then they say that the central incisor should be restored as well, in order to achieve a result that provide a healthy, natural smile. And we know that we have, one more time, a mean of the frontal teeth dimension, but actually those dimensions are not so important. What really can change a smile and make that smile balanced on our patient's face are the proportion. It is the same slide I show you at the beginning. We have to respect those proportions, or actually we don't have to take those proportions in a really strict way, but we really have to try to use those kind of proportions to make looking a smile more natural and balanced. So I want to share with you those three cases because those patients, they have different ages, different sex, different expectations, but they have some stuff in common. So we have here one case of two missing lateral incisor. Here we have one missed lateral incisor and one peg-shaped lateral incisor. And here we have two peg-shaped lateral incisors. And so let's start with the first case, a pretty young patient, 16 years old. So she finished an ortho treatment, not in my office, in another one. And her chief complaint was about the teeth shade. And but we can immediately see that actually there is a lot of other stuff going on that we would like to improve. So we start, as always, with a face and smile analysis, and then we move inside, and we can see here this Maryland bridge that we actually could improve a lot. And as well, we can see here this temporary crown that is pretty poor for the aesthetic reason, but as well for the pathologic reason, because here there is a high risk of cavities. So as you can see here from that picture, the first thing I did, it was a bleaching, because she wasn't trusting anymore in dentists. So she told me that her chief complaint was about the shade. So okay, so just to show her that I was listening her, I did bleaching, and then we can figure out how we can improve. So 16-year-old, of course, very, very too young for dental, for implants, in particular in aesthetic region. And we can see, we can measure here the space, and as well here, they're not exactly the same, but as I told you, we can play with the shape and the shade. And if we measure those teeth, we can already see that they are a little bit too narrow compared to the lateral incisor. So what I did, I asked to my technician to make those little envelope in resin, just to understand if increasing a little bit the wide, the smile could look more balanced smile and nice, sorry. Here there was a soft tissue augmentation, because of course when we don't have tooth, so as well the root is missing, we are going to have a little bit of concavity. And of course, those are temporary crown. Of course, I changed the temporary to provide a nice smile. And I made the chew very easy, very simple. I always try to keep everything as simply as possible. So here is the shade selection, and I changed a little bit. I increased a little bit the length of the not the length, sorry, the wider of the central incisor. And how are we gonna end it? So here I like to draw with a pencil the texture of the teeth that I'm gonna provide. Here we can see finally the tissues that are ready for the final restoration. So we have no doubts for the peg shape. We are gonna restore it with a ceramic crown. But what about the lateral incisor? Too early for implant for sure. So those are some pictures that I like to share with my dental technician, just to try to have the nicest work as possible. And what I decided to make for that lateral incisor, it was a lithium disilicate Maryland bridge. It is not a very, it is a case that I did some years ago. Actually, nowadays I would do zirconia with some ceramics that we can makes adhesion with the dentin, but at that time I did it with the lithium disilicate. But we know that we really have to follow some rules in order to avoid any fracture, and we have this kind of rules that we have to respect. And actually, so I checked the thickness of the lithium disilicate, so I made it. And here it is immediately after bonding of the restoration and the X-ray, and here. And we have to take those kind of picture, because immediately after bonding, I took that picture and I saw that maybe I enlarged a little bit too much that central incisor, so I fix it. So we really have to make as many pictures as possible in order to fix our little mistake that we can really fix very easily. And we can see here our outcome. I think that those picture is about 1 year follow-up. Then I never seen again the patient. And here still a little bit scar after the perio-surgery, but it's a really tiny scar that we can appreciate only with this kind of picture. And here, that's the final result. One more time, I'm always trying to fix in the easiest way as possible all drawbacks of the smile. One more case, extremely young patient, 14 years old only. As well, he did an ortho treatment, but of course, he wanted to improve his smile aesthetics. And those are the picture after an ortho treatment that it was made by another orthodontist in the same office where I'm working. And then he sent him to me as well. This one more time is a pretty old case. So as usual, face and smile analysis, we check the proportion, and then after that we make our treatment plan. We can start. In that case, I decided to restore 100% with the direct composite, basically for the age and as well for the tissue. And that's what I did. So it's a pretty old case, and I'm not working anymore with those materials, but actually the procedure are always the same. So first of all, the palatal surface, then dentin. We can play a little bit with some effects, and then the final layer of enamel. And that's what we got. That's the picture I shared with you at the very beginning of this presentation. But what we want to see, of course, is the occlusion, of course, is the lateral view. But what we really want to see, of course, is the full, the smile and the full smile picture, in order to understand if we really achieved what we planned and what we wanted. And that's the follow-up. And this is Malta, a pretty sunny, pretty nice island, and that's the institution where I'm working for. And this is my email address if you need any information about cases or as well about this institution. And let's see the last case. So this 30 years old woman, she really wanted to improve her smile aesthetics. And those are some pictures. As I told you, look, we really have to check the teeth exposure at rest and the smile and a normal, a natural smile. And of course, we have to check with a lot of picture. In particular, in a case like that, and I think in every ortho and restorative case, where this teeth is a canine and this teeth is central incisor, and those are the premolar. And as well, one more time, a very careful smile analysis, and one more time, the teeth exposure and the smile arc. So that's our starting point. Of course, at the beginning of every case, as I told you in advance, we really need to check the tissues and the oral health. So first of all, we really need to remove the old calculus and plaques, and we have to restore the old cavities. And in a case like that, at the very beginning, we really need to understand what provocated this kind of abrasion and this kind of erosion, in order to stop it, and then we can make our treatment plan. As you can see, she underwent an ortho treatment when she was pretty young, and one of her requests was to don't wear braces, but just to try to fix the smile in the best way as possible. Of course, I told her is not a matter ortho yes or ortho not. Is the matter to achieve the aesthetics and the excellence in both aesthetics and function. And here you can see edge-to-edge occlusion. So of course we cannot restore those teeth because everything is gonna break. Composite, ceramics, zirconia, everything is gonna chip or break something because of the occlusion, of course. So one more time, our starting point, it is the check the face, the smile, in order to planning the most balanced smile. And of course, we have to look at those cases with an ortho view and as well an restorative view in order to respect that proportion. So that the our smile analysis, and that's how we would need to improve those teeth in order to make them looking natural. So of course the canine are already on the place of the lateral, so we are gonna restore them just to make them looking like a lateral incisor. And so I took the impression, of course, with the face bow, and we checked the occlusion, and I increased the VDO to restore the teeth that they were abraded and eroded, and we made, of course, a wax up, and I made one indirect mock-up on the posterior just to check if my planning was right or not. And then I printed the semi-direct mock-up directly on the patient. And after we do that, you can see just printed, we can fix exactly like a direct composite, and then we can check the smile and the function. That's the key role. And we can take some picture with the mock-up, that is just our project, and we can check the proportion, and it is 100% removable and reversible. So if they look too long, I just need to take my diamond disc and drill a little bit, and of course we can check the proportion, and we can make the whole phonetics and the speaking and chewing analysis that we want. And only when we are 100% sure, we can move to the final restoration. Those are the tabletop to increase the DVO and to restore the abraded tooth. And of course, she wanted the lower incisor and canine aligned. But how can we do that? It's pretty, actually, it's not that difficult to solve this crowding, but we have to think about the occlusion that we just saw. If you remember, it was an edge-to-edge occlusion. Of course, opening a little bit the video, I gained a little bit of space, but for sure not enough space to align them. Sorry, to push them, all of them forward, because if I put some braces and use just a night eye arch wire, all of those teeth, they would move forward. But of course, I cannot permit something like that because I don't have space enough. So I really need to keep that line and to restore them. And as well, those teeth are abraded like the others, so I really need to restore them in order to achieve the right function, exactly as I show you. So that's our plan, and that's what I did basically only with a direct composite. So I did a little bit of IPR, exactly like we do in ortho when it's needed, but just a minimum thickness, just to allow me to insert correctly the matrix, and then I restored them. And I made a camouflage. So they are misaligned, but I made them to look like aligned. So here is the starting point. Here is just remove the rubber dam. You can see here still it's before the finishing, some composite layered in a rough way, but they already looked aligned in the very minimal way, and that's after finishing and polishing. And we can see, of course, I restore them, I make them longer, of course. This for both aesthetics, that for both aesthetics and function as well. And doing that, we can actually make them looking aligned. And that's a nice way to prepare the teeth in case of veneer with a blue mock-up, as suggested by my friend Luca Tacchini. And that's the teeth prepared. You can see some teeth are more prepared, other way less, because it's not a matter of philosophy, prep or no prep. We need to prep only where is needed. And here, you can see here is a little bit more prepared because I wanted to fix as well the midline. This time, not with braces, this time with veneers. But actually, one more time, we really need to look at our cases and our patient with one eye, with the ortho way, and another way in a restorative way. And so after that everything is settled, and after that everything is right, so we are able to finish our case and to cement the final restoration with no surprise. So that's my try-in. Here you can see a little bit of pencil because I'm checking the gingival level and other stuff, and that's the cementation. I'm seeing that I'm a little bit late, so I'm going faster. And of course, as well, the cementation. And so we made a kind of journey with all of these patients. So it's time to land and let them go with the best smile that we were actually able to provide them. And that's what we achieved with the full adhesive full adhesive workflow. And here as well, as you can see, I tried to fix the midline. And finally, you can see here the new overjet, new overbite. So basically, it means new aesthetics and new function. And here, of course, we really have to take care about the tissue. So those are the tissue some weeks after cementation. And that's finally the correct, the right teeth and smile exposure. And that's what we want to see at the end. Maybe some of you could say that those laterals look slightly too big, but they are perfectly balanced with the central incisors and the canine. And those are canine actually, and those are premolars. And here, of course, we want to check the lateral view, and I think that nobody can say that it's a case of both missing lateral incisors. And here it's a more natural smile when finally the patient can show as well the lower incisor, and we can not see the lip like in the picture before the treatment. So what I wanna say to you at the end, before the question time, every day we work with a lot of different smiles with the different aesthetics that they belong to different patients with different expectation and different possibilities. So we really have to follow the right protocols for the procedure that we were going to perform. Everything needs to be decided at the beginning and not at the end. So we cannot end ortho treatment and then say to the patient, you know what, you would need some veneers on restoration. We really need to decide everything at the beginning. When we design a tailored treatment plan for that specific patient in order to achieve the best result that we can for that patient. And to achieve that, we really need to work with a nice team, with a balanced team that everyone work together perfectly, where everything is matching. So the dental hygienist, the orthodontics, the restorative, and of course, I really think that the pilot of the case is the patient. We really need to train the patient about oral hygiene, and he or she really needs to follow our instruction, because we are those mechanics, construction, and we are providing him or her the best car we can, but actually the patient is the final pilot. So I really want to thank you for your kind attention. And please, if you have any request or question, just feel free to ask. And here you can see my email if you want to ask me anything, or even if you want to criticize. All critics are more than welcome, of course. So thank you very much.
Thank you so much, Dr. Elio, for such a wonderful lecture. It's been ages since, as an orthodontist, I'm practicing only orthodontics since 2000 now, because in 2000 I joined my post-graduation, and since then I'm doing only orthodontics. But this has, I would say that ignited a little bit of passion in me about adhesion also, that is restorative dentistry. So I would definitely try to learn a little bit about that, so that sometimes we do, as an orthodontist, we do come across a lot of cases where the black triangle is the biggest problem for us. You know, whatever.
Yeah, but what I really wanted to, what I really want to share with you is that, for instance, in the cases of agenesis or lateral incisor reduction, there really has to be a good cooperation with ortho and resto. Or if the ortho does restorative, that's great, because if we just closed all the spaces, the smile is not going to be balanced. Exactly. Right? For the proportion I show you. So the ortho need to open or maybe close a little bit, but not all the spaces, in order to provide the right proportion for the restorative dentist. If everything is planned at the beginning, it's gonna be great. Otherwise, you know, it's way more difficult.
Yeah, that's what in aesthetic they always tell. In orthodontics also, we always tell our residents that always begin with end in mind.
Exactly, as David Server said, as Lawrence Moser, another friend of mine, said, we really have to start with end in mind. That's
and you know Dr. Jean-Marc Retrové as well, who will be our tomorrow's speaker. You know him very well. So he also says the same thing. Now, let me just tell our panelists if they can just put some words for him. Dr. Kamal, Dr. Mandava, and Dr. Sonali. If any one of you can just have some word about him. Meanwhile, I'll just go through the question answer and read it. Meanwhile, if you can just put some words for his presentation. Dr. Kamal?
Yeah. Good evening, Dr. Elio. It was a wonderful presentation. I know I'm doing adhesive dentistry alone. I am not doing any ortho, but I had seen so many cases you showed that an ortho plus restorative can do wonderful things, wonderful jobs. It was a wonderful presentation and learned a lot from you. Thank you.
Thank you very much. It's
Dr.
a great
Sonali?
pleasure and honor for me.
Hello, doctor. It was an amazing presentation by you. It conveyed all the aspects of micro and macro aesthetics. It's often challenging, that I understand, to take up multidisciplinary cases. And I see a lot of efforts have been taken by you and your team to apply all the principles of aesthetic dentistry along with orthodontics to achieve the best functional result. And I'm very sure this presentation has been an eye-opener for many budding perfectionists to come up to the best results. I thank you again very much for enlightening us on this specific topic.
Thank you, Dr. Sonali.
Thank you very much. Very
Though
kind of you.
she looks very young, but she is a dean and principal of one of the dental school in India as well.
Okay.
Right.
Thank you. I'm honored.
Yeah. Thank you, Dr. Sonali, for your kind words. Dr. Mandava? Dr. Mandava Prasad, are you there? I think. Okay, let me have questions.
Yeah, sure.
Yeah, there's a question, sir, in the first few slides. This is a question from Dr. Sindhu.
Yeah, sure.
Where we discussed about photographic analysis of a female case for proper diagnosis. Apparent canting seems to be due to a differential lip mobility bilaterally. How can we differentiate hard tissue, that is teeth, versus soft tissue defect for diagnosis? And how to take care of a differential lip mobility if it is the cause?
Okay, so basically we can check if just if it is the lip mobility, if we took a picture and we really need to be parallel to the horizontal line. And we can do it with a picture that is taken in the right way. So this one is the first, and we can see the lip asymmetry first. Second, maybe we could have an asymmetry on the occlusal plane. So I would recommend you to use very easy, just a face bow with you know, a face bow that if there is a canted occlusal plane, the face bow is going to be canted. So in that way, and if still you have some doubts about hard tissues, you can take frontal X-ray, and it's something that I do hardly ever. But in some very tough cases, or in you know, some doubts, when you have a lot of doubts about the diagnosis, you can take, you know, the frontal X-rays. Because I don't know if I'm saying that rightly, because in Italian it is named frontal posterior
we call it a posterior encephalograph.
And you can check it, and you can you can check it. But by the way, most of the time when you have occlusal plane that is canted, you can, most of the time you can fix it even orthodontically, some with the mini screw and so on. If the if it is a really tough cases with a lot of discrepancy, it's going to be orthodontic surgery case. I don't know, Dr. Haji, if you agree, but you know, depends on
it's basically
the level
it's basically a problem with the roll, right? If at all there is a soft tissue problem, sorry, hard tissue, then it is a problem of a roll. And if there is a soft tissue problem, then we cannot do anything other than lip repositioning procedure. Okay.
Yeah.
Now next question is from Dr. Niranjan Vatka. Hi, Elio. In case patient doesn't choose pre-orthodontic treatment before restorative, what is your approach? You're putting him in a fix, Dr. Niranjan, I guess.
Sorry?
I said he's asking that if patient doesn't want a pre-orthodontic treatment before restoration. I said you are putting the Elio in a fix because he's talking in front of an orthodontic crowd.
No. It's a great question. So by the way, I always try to make ortho, and I explain to the patient, you know, the big advantages. Then basically it's if we do ortho before, we can really be minimal invasive or even not invasive at all. If he or she, usually those are female, doesn't want at all ortho, as I showed you, sometimes I use a lingual orthodontics, and I would have a lot of other cases that I didn't share with you, basically for time reasons, but just 1 second. For instance, a cases like this, for aesthetic reason, she wanted to replace those crowns. So what we can do, of course, those are the zenith for our goal. We cannot just replace those crowns if we want a nice result. But one more time, she told me, no way I'm gonna wear braces because we needed to, you know, extrude the lateral. And what about mucogingival surgery? Maybe it's an option. It wouldn't work so well in my hands, but I wouldn't consider that. So of course she said, no way, like the others, that I'm gonna wear braces. And of course, it's something that we can do with aligners, you know, attachment and so on, but it's gonna be pretty slow. So what I did one more time, I just bonded directly this arch wire and lingually, and we have a lot of advantages to do that. Basically, because we know that article by Hochman, pretty famous, and it is citated a lot of times. So if we provide a vestibular vertical force, we are going to have an uncontrolled root tipping, and we're going to have a bone resorption. So, but it is changed completely if we put a force not in the vestibular surface, and we have this rotation that I mentioned you due to the distance. But if we do it from the labial surface, it's gonna change completely the root movement, and you're gonna see that as well tomorrow with the great Dr. Jean-Marc Retouvi. And basically, because the distance here, it's completely different. So in that way, basically for that reason, I decided to put a lingual arch wire. For that reason, and as well for aesthetic reasons.
Because we are working very close to the center of resistance, and
exactly. So in that way, here, for instance, a case like this one. Sorry, my touch bar is not working anymore.
No
but I'm coming.
Yeah.
So
it's here on the second.
So there, in a case like that one, you can see just with lingual ortho, so 0 surgery, 0 no surgery at all. How much gum we gained, and those of course are temporary. And look at the tissue. So I always try to push the patient to do a little bit of ortho previously, and that's what we can achieve just with ortho combined to prosto. And here that's the final restoration, and here you can see the amount of the tissue that we gained with no surgery. So, but by the way, going back to the question, sometimes it happened that there is no way basically for timing that the patient can do ortho. Maybe for, you know, there is a wedding, or she or he, they will move. So in that way, I'm telling them that I'm gonna be a little bit more invasive, because we need some space for composite, but for composite just a little bit, but for ceramics. And so of course, if the patient is okay to drill a little bit more of enamel and maybe dentin, okay, sometimes it happened that I do just restorative, not previous, without ortho previously. Yeah, of course it happens.
Thank you.
But you really need to explain to the patient rightly.
Okay. The next question is from Dr. Stefan De Souza. Could you send the articles by Rosa and Zakirashan?
Yeah, of course. You send me an email. I send you the article of Zakirashan and Rosa. But there are a lot of articles that they they talk about this this topic that I really like and I really care. But of course, I'm gonna send you. Sure.
Okay, Dr. Niranjan Vatkar, do you treat all cases in CR or MIP?
That's a great question. Very hot topic nowadays in Italy and around Europe, and I guess as well in
India
all over
also.
the world. Yeah, in India, all over the world for sure. So basically, it depends on how many teeth the patient have, and how much I'm gonna open up the vertical dimension. For instance, the case like that you just saw, I opened in MIP, like very similar to the three-step technique, and of yeah, and but other time I do it with CR. Depends actually, but yeah, the cases that I show you, I showed you the one of the abrasion and abrasion and erosion. I did it with MIP because basically, of course, I tried it with the mockup. I checked the molar class, canine class, and of course, I did some functional analysis and as well aesthetics analysis, and I did it in that way. Yes.
Okay, thank you. Dr. Mandip Shilpi is asking, so please name the instrument to check proportion of tooth.
Yeah. So. The smile or the tooth. So the tooth is like that one, and it is made by Ufridi, and it is named Chu Gauge because it is designed by Stephen Chu from Columbia University, and it is that one. It is made by Ufridi, and basically it checks the proportion between the height and length of the crown. And but one of the most important is that one. What is that? No, I'm arriving. Is that one? There we are. Only 1 second. Okay. So basically it's just a Keynote or PowerPoint, as you prefer. No any magical software. We don't need that. Actually, I used sometimes I use some software for smile design. They are nice, but basically we just need a printed picture and a pencil or a pen, or just maybe Keynote or PowerPoint. Basically, those are the. So as you can see, those are the frontal proportion. So it means that here, those distance are in perspective, right? Are not the real length, is not the right measured distal width of the teeth. It's just, perspective. So basically, they are not a golden proportion, they are red proportion at the 70%. Basically means that the lateral incisor, this distance is the 30% less of that one, and that distance is the 30% less than that one. Of course, those are the meaning, so we don't have to follow those lines in a very strict way. But I think, it's something that can allow you to check the smile of the patient and immediately figure out how far you are from the ideal proportion. It's something that I do pretty often. I think that is very easy, extremely easy, and pretty useful. I like to work with easy procedure because those are more predictable, and because the nature is easy. The nature doesn't like complicated stuff.
Okay. The next question is from Dr. Stephen D'Souza. Could you have done the last case by Dahl technique?
One more time, sorry.
It's DAHL, Dahl technique.
Can I the actual where is the question?
Can I take him on a line? Just a minute. Stephen De Souza. Okay. Yeah, Dr. Stephen.
Yeah, I saw that.
Okay.
Which case? The one with the one the.
Just a minute. Dr. Stephen, can you talk? Like I have allowed you to talk. Can you just ask your question?
Hello.
Yeah.
Yeah. Am I audible?
Yes, you are audible.
Yeah.
Yeah. So the last case where you increased the vertical dimension, could you have done that with the dial technique?
I'm checking which is the dial technique. Actually, I don't know.
Okay, so it's like where you add the composites on the linguals, the palatals of the upper anteriors. And
are you? Yeah. Like with the jig, right? With the Lucia jig.
Yes.
Yeah, for sure. But look, it's most of the time. I during even the first visit, I made with the resin, sometimes composite resin. I increase a little bit the, I put some composite on the palatal surface of the central incisor, and I check the occlusion. But in that case, as I show you, I increased the all lower teeth dimension and as well upper. So I did, as you just said, during the first visit, I check how much I needed to open to achieve both aesthetics and function. But then, it was my project. Then I asked the technician to make some temporary, as you saw, some of them were semi-direct and other were indirect, because I checked everything directly on the mouth of the patient, because it was a full mouth rehabilitation. So when we do some cases that are pretty extended, like those one, of course, we have to planning everything, but we have as well to try directly on the mouth of the patient, because we are changing both upper and lower teeth.
Thank you. Thanks a lot.
Okay. Now, Dr. Sherfaraz Bangi, which company composite do you use?
Which brand? So I'm using Shofu, that they are Japanese composite, and I'm working a lot with that company as well for cements and ceramics. I don't have any financial interest. Yeah, but yeah, I'm one of them opinion leader in Italy. I'm trying a lot of their materials.
Okay. The next question is from Dr. Shakti Kumar. Good evening, sir. My question is, how do you look at smile rehabilitation in post-COVID-19 phase, when face mask will be mandatory for everybody?
Yeah, absolutely. It's a big issue. What I saw for my private practice, that patients they are not still they don't still figure out that they are gonna wear the mask for a long time, unfortunately. So I'm still doing some aesthetic cases. But for sure, it's going to be a problem, because if the patient realize that they cannot show anymore their wonderful smile, it's going to be a problem. Yeah.
It will be a big problem for orthodontists rather than restorative.
For everyone, everyone. Yeah.
Dr. Swapna Puri is asking, in last case, Dr. Boschetti has increased the height of occlusion in order to lengthen the incisors. Can it create any TMJ issues?
So depends how much you are gonna open up. In that case, sorry, I didn't open that much. I opened a little bit. I opened on posterior molar 2 millimeters. So in the anterior, I gained almost 5. Now I have the all numbers right in my office here. No. maybe a little bit less, a little bit more. So, but if you, so according to Mauro Fradiani, if you stay not more than 2.5 on posterior, you basically, you cannot cause any TMJ problem. But what I really suggest you, it happened to me to open way more, but what I really suggest you is to check the case. A case like that one, it was eroded and abraded. So actually I was kind of replacing what the patient missed. It happened to me to open more than what I mentioned you. So what we can do, and it is a very smart way, so you have to plan your cases, then you can print the mock-up, direct, indirect, whatever you want, and then leave that on the patient, because you are 100% reversible, and leave that to the patient for a certain amount of time. So the patient can smile, speak, chew, okay? And so you can immediately check, if everything is working or not. So in cases, in some limit cases that they are kind of dangerous, I leave the temporary for some month, and I check it. Yeah.
Okay. Next question is from Dr. Preeti Bardwaj. Good evening. Which polishing kit do you use?
So first of all, if you want to have some very glossy and nice restoration, we really have to layer the composite properly. That's the first step. Second, we really, try to avoid any bubble, gap, and so on. And then usually I'm using a flame burr, with a very thin diamond. And then I use basically I like very much the